Here I want to say one scenario. I will tell one scenario how the patient comes to us for the labor delivery. You can decide this scenario, huh? Just here, from here.
A 22-year-old gravida 2 present to labor and delivery at 39 and 5 or 7 weeks gestation, complaining of painful contraction. She noted that the contraction started to increase in frequency and became painful 6
Can
hours.
you understand only slowly? You understand? Okay. Continue.
The contraction started to increase in frequency and became painful 6 hours before coming to the hospital. She has had no leakage of fluid and no vaginal bleeding, and she has noted good fetal movement. Her obstetric history is significant for one prior uncomplicated full-term vaginal delivery of a 6-pound, 2-ounce infant. She is contracting every 4 minutes. Her cervical examination, it was 4 cm dilated, 50% effaced and -1 station. The fetal vertex is palpated on cervical examination. Fetal heart monitoring is reassuring and reactive. The patient requested an epidural for pain relief. 2 hours later, the cervical examination is 6 cm dilated, 100% effaced and -1 station, and artificial rupture of membrane is accomplished. The amniotic fluid is clear. 4 hours later, the cervical examination reveals that 8 cm of dilation. After an additional hour, the patient is found to have a fully dilated cervix and begins pushing. After 40 minutes of pushing, the infant delivers easily.
So there is some term. You see that there is a scenario. What is first sentence is the gravida 2 para 1, okay? And she came with the complaint of, where is that? So here a scenario, I present you a scenario, that is, she is 39 weeks. She came with 39 weeks of pregnancy. So it is a normal labor or not? Good. And complaining of painful uterine contraction. Okay? There is some normal contraction, there is criteria of normal contraction, there is. It is true labor pain or false labor pain. There is a term Braxtonix Contraction. There is normally uterus is smooth muscle. There is how contraction even, there is interaction between actin and myosin, you know. And for contraction there is need ATP and enzyme. ATP energy and also some enzyme needed. There is contraction. So Braxtonix contraction normally when uterus is grown up and development of the fetus and on the process of development, the smooth muscle is contracts and relax, and ultimately become the larger. So when there is usually after 16 weeks, there is in the uterus there is some contraction and relaxation. That is called Braxtonix contraction. It is sometimes perceptible, sometimes not perceptible by the body. Most of the time it is not perceptible by the mother. Ultimately it goes to the labor pain. So there are some factors for the labor pain. There is stretching by home, distension of the uterus. Uterus become distended by the growing fetus, liquor, placenta, right? Your normal uterus, how much it is? Like this only, maximum 9 centimeter. And it becomes how much? Not like 36 centimeter. After when 40 centimeter, it is slightly down. 36 centimeter. So you can imagine how it is. There is growth and development of the uterus by the muscle hypertrophy and hyperplasia of the smooth muscle. So obviously there is stretching in the uterine wall. There is a stretching of the uterine wall. Can you follow the classes or not? But so number 1 is distension and stretching. Number two, some hormonal factors. You know the oxytocin? What causes oxytocin? What causes? It causes contraction of the smooth muscle. It is increases at the later part of the pregnancy and labor is pick up. When labor starts, its secretion is pick up. From where it comes? Oxytocin? Posterior pituitary gland. So, and receptor sensitivity is increased. There hormone where it acts? In the receptor. So, in the receptor there is increase of number of the receptor at term and also in the labor. So, there is increased sensitivity of the oxytocin, and there is more secretion of the prostaglandin. More secretion of the there is receptor, prostaglandin, and estrogen. Estrogen also causes some role in the starting of the labor pain. Okay. So, as I told, in the later part of the pregnancy, you saw there is a normal, there is a common complaint is lower abdominal pain. So, sometimes it misguided. For what misguided? There may be, sometimes they understood the labor pain. But so labor pain, there is a criteria. You should know this one. What is the criteria of the labor pain or uterine contraction? Gradually it is gradually it increases in the intensity. In frequency will be increased. And and duration. Duration also ultimate there is contractionary duration barbe na kombe? Barbe. So time of, that is duration of the contraction. So frequency, intensity and duration of the contraction will be gradually increased. But if it is pain associated with constipation, if it's a urinary tract infection, cystitis, or round ligament spasm, or any other cause of the other organ, it will be like this or not. So it will be not like this. So that is called false labor pain. Okay, that is called false labor pain. So you should categorize what is normal labor pain, what is abnormal labor pain. So away from this criteria, it should be abnormal. Okay. Now there is, I am telling now, you see then the patient come to the hospital 6 hours prior to her pain. She had no leakage of fluid. What is what fluid leakage? Amniotic fluid. If there is a membrane rupture, there is leakage. But there is abnormal discharge. Before starting of the labor, there is some more secretion in the vaginal cavity in the cervix. See, there is gush of, sometimes there is a gush of fluid from the collected secretion in the vagina. So sometimes confused. There is rupture membrane or excessive watery discharge. Okay. Next, the patient, she had good fetal movement. So perception of the fetal movement is the important. That is, we check the fetal monitoring. You know the partograph. Today I missed something. I cannot open my pen drive, so I cannot show you in the PowerPoint presentation. Later, when I get time, I will present. You know, I think all of you know the partograph. There is a recording paper of labor attached in the labor room to monitor the fetal condition and maternal condition during labor. Understand? There is a graphical representation. What is a partograph? There is a graphical representation of the fetal and maternal conditions, the progressive changes during labor in a paper. That is important. It is a tool. It is needed to see labor is progressive or not progressive. Labor is arrested or not. To show this, so there is a there is a graphical paper. I show you just. So at first it needs a man. Who is the mother? So identity, name of the mother of the patient, like this, is time of admission, Time of admission, huh? Time of admission, okay? Then at first fetal monitoring, that is my fetal. Pulse, the importance and blood pressure. Fetal heart rate, some components. I think all of us know about the partograph, huh? Fetal heart rate. Molding, membrane rupture or not. So there is a partograph has mainly two components, and that is maternal components and fetal components. Fetal components, what is needed, fetal heart rate, molding, and then descent. And maternal components, maternal identity, that is who is the mother, name, age, like this, time of admission, and then with the findings of the maternal, that is cervix, condition of the cervix. What is the condition? What we say, the dilatation of the cervix, and what is the others? Dilatation and effacement is the same. You heard the name effacement? Effacement is the thinning of the cervix. We know the cervix has some thickness. Cervix is, at first there is, that is, what is this? Soft, firm and hard, like this. What is needed for the dilatation of the cervix? It needs softening. Must be softened. And how it is softened? There is some changes in the collagen fibers and some water accumulation in the cervix at term. So it changes the consistency of the cervix. It becomes softer. So thinning and taken up of the cervix with the lower uterine segment. Can you imagine the uterus, upper uterine segment, lower uterine segment? So suppose this one, this is upper uterine segment, lower uterine segment. Here is the cervix. Suppose cervix length this, breadth this, and gradually when it is dilated, it becomes changes to like this, like thinning of the cervix, thinning of the cervix, and it must with the lower uterine segment. There is no differentiation between the cervix and the uterus. This cervix become masked with the lower uterine segment of the uterus. Understand? So it is thinner and become masked with the lower uterine segment. That is called effacement. Okay? So that is effacement. Effacement. Okay? That is essential for the normal labor. For progressive dilatation of the cervix. Progressive, that is gradually. It is, suppose at first one finger, then two finger, three finger, four finger, like this. Suppose your finger is 1.5 centimeter, that is one finger. If it then 2 centimeter, that is 2.5 to 3 centimeter. Or if you push the one finger into the internal os, 1 centimeter, that is one finger. That is usually 1.5 centimeter. If two finger, that is 3 centimeter usually. Then full dilatation, how much centimeter? 10 centimeter. Full dilatation means 10 centimeter. You cannot feel the cervix. Cervix is already taken up by the, we cannot feel the cervix. It is taken by the lower uterine segment.